Hello and welcome again for Conversations in Interventional Cardiology. My name is Sahil Parikh from Columbia University in New York, and I'm delighted to be joined by several old friends. Tonight with us, we have Dr. Scott Kinley from the West Roxbury VA and the Brigham and Women's Hospital in Boston. He'll be our presenter, and then two other colleagues, also previously trained in Boston like me, Marc Bonaca, now at Denver Health and University of Colorado, and his partner there, Kevin Rogers. All of us are vascular medicine and interested in interventions. And without further ado, Scott, why don't you tell us about the FAROUT study? We'll start with a few slides and then we'll have a discussion.
I'd love to. Thank you very much for that introduction. And it's a great pleasure to present this paper on long-term adverse limb events after femoral artery endovascular revascularization from the Boston FAROUT study. And on behalf of my co-authors, Edwin Mandika and Ramel Ahayambaba, who are both at the Brigham and Women's Hospital as fellows, Piotr Sobiechik, who is a vascular interventional cardiology specialist at the Brigham, Andy Eisenhower, who was at the Brigham, and Thomas Todderin, who's at the Medical University of South Carolina. So what we aimed to do with this particular study was to look at patients with successful femoral artery revascularization for claudication or chronic limb-threatening ischemia between 2003 and 2011 at VA Boston and the Brigham and Women's Hospital. Demographics and procedural factors were taken from the medical record, and lesion length, task class, and tibial runoff from procedural angiograms. And we looked at the outcomes of major adverse limb events or MAIL, or minor revascularization, or components of that combined endpoint. And we used Cox proportional hazard models and competing risks models to assess the risks for various factors and these outcomes. So we had 232 limbs among 185 patients. They were predominantly men and white, which reflected primarily the demographics of the VA and the northeast of the US. And over a mean 9.3 years, we found 88 limbs with male or minor revascularization. Of these, 78, 34% of limbs were for repeat endovascular revascularization, 20 were for male, 11 for major amputations, and 9 for surgical bypass. And this was the primary finding, was that lesion length was very strongly related to male or minor revascularization over 10 years. With lesion lengths over 200 being particularly at high risk for this endpoint. But then when we looked at the factors related to lesion lengths and many of the procedural factors, the presence of chronic total occlusion, pre-procedural ABI, for example, were related to lesion lengths. And so there were more CTOs with longer lesion lengths, there were worse ABIs with longer lesion lengths, and task A or B lesions were more common with the shorter lesion lengths. Number of stent use obviously was related to lesion length, and the use of atherectomy or lumen reentry devices were also related to longer lesion lengths. So this suggested that many of the procedural factors were very closely related to lesion length. And then we looked at the components of the primary endpoint. So here we see column graphs showing male or minor revascularization by lesion length here on the x-axis. And you can see that lesion length was strongly related to male or minor revascularization. But when we looked at minor revascularization in the hatched columns, you can see it was very closely related to minor revascularization, but it wasn't related to male. On the other hand, the presence of chronic limb-threatening ischemia was very closely related to male, but not really related to minor revascularization. And it was male that was driving the combined endpoint. The presence of a chronic total occlusion didn't really relate to any of the limb-related outcomes. So we did multivariate hazard models looking at male or minor revascularization, the first column here, male alone, or minor revascularization alone, which was primarily repeat endovascular revascularization. And we found that lesion length was strongly related to the primary endpoint, but mainly driven by repeat minor revascularization. On the other hand, chronic limb-threatening ischemia was related to the major endpoint primarily through an increased risk of male. Smoking and current smoking was as strongly related to the combined endpoint, but again, mainly through repeat endovascular revascularization. And then surprisingly, we found that male was strongly related to black race and also to elevated LDL cholesterol. So we found in conclusion that male major adverse limb events and minor revascularization are related to quality of life and mobility. We know that from prior studies. And the factors related to the combined endpoint of male or minor revascularization included chronic limb-threatening ischemia, smoking, and lesion length. But these were being driven differently. There was a dichotomy. Male was primarily driven by chronic limb-threatening ischemia, black race, and elevated LDL cholesterol, whereas repeat endovascular revascularization, minor revascularization, was mainly related to longer lesion length and the presence of current smoking. So I would like to end that little summary there.
Great. Thank you so much, Scott. It's a great overview of an interesting longitudinal data set, one that we don't often see. Patients with claudication or CLTI with successful endo-revasc over the course of almost a decade. In fact, this was so long ago that Marc and I were both trainees during this period, and there's a non-zero probability that we cared for some of the subjects in the study. So at first blush, I want to ask both of you, Marc and Kevin, what are your reactions to the data and the conclusions? To some, they might seem obvious. Those of us that are lunch pail interventionalists who take care of a lot of vascular medicine patients probably would relate to some of the findings. But I want to get your gestalt. What do you think? First, Marc, and then Kevin.
Well, it's a very nice study, and the long duration of follow-up is really, really fantastic. And I know the records within the VA system really allow you to have excellent follow-up. So kudos to you and your team. I think one of the takeaways for me is the heterogeneity in the drivers of these limb outcomes. That we think sometimes of these composites that everything is driven by the same thing, but I think particularly in peripheral artery disease, as we look at the spectrum of bad things that happen to legs, whether it's progressive symptoms down to sort of minor amputations, it might be microvascular disease, that there's a lot of heterogeneity in the biology. And I think that's been a problem in terms of therapeutic development, of understanding what pathways to target. And I think this study really does a nice job of highlighting those different drivers for the different outcomes. I'll also say it struck me that as we see in many studies, that there were disparities by race in terms of outcome, and obviously those are other factors, and a reminder that we need to think about that as we provide equity in our care. That'd be a great study.
Kevin?
Yeah, there's several things I really liked about this study. I think first and foremost, I really liked how the study population was defined. I mean, I think this SFA problem, I find it super prevalent in my practice. I think it's a very prevalent anatomic pattern of disease, and I think it's super challenging to revascularize it and get a good result. So to have a patient population who's undergone lower extremity revascularization specifically for SFA disease, I find super interesting. And then to have the 10-year follow-up for it is just great. And so the outcomes, I mean, there's a number of events. It's not inconsequential by any means, but it's in the ballpark of what we see in other big trials like Best CLI, Basel II, Voyager. But it's not so discouraging that we can't keep improving and try to make the interventional outcomes better. But it does catch your, it's a nicely reported, honest outcome adjudication, and it gives you a note of something you can improve on.
So Scott, what's obvious to me, so my interest in local drug delivery is longstanding, and the era during which these patients were treated was really pre-drug delivery for endovascular intervention in the FEMPOP segment. Drug-coated balloons were probably FDA approved just towards the tail end of that period. So from a technological standpoint, my guess is that most of these patients were treated with a combination of angioplasty plus or minus and probably nitinol self-expanding stents. Is that fair?
That is fair. And I mean, I think that's a really good comment to make, is what's the technology nowadays? How's that going to influence these outcomes? And I think that you can imagine that the drug-coated technologies are going to have a major impact on the repeat minor revascularization. And because that's related to lesion length, that's related to smoking, and that's related to that biology, a chronic indolent biology where you get restenosis. So I think that's going to make a major impact there. But it does make me wonder whether these technologies are going to impact the male endpoints, limb loss, and that's strongly related to critical limb ischemia, chronic limb ischemia, and LDL. Perhaps other interventions are going to be required to prevent those.
Well, that's exactly where I was going. I think that we've known for a long time that restenosis has been a function of length in the non-drug coated devices. And if you look at Imperial and a number of other drug-eluting stent and drug-coated balloon studies, you basically flatten the slope that relates the relationship of length to restenosis. And so tobacco use, diabetes, they probably will fall in similar buckets. Although maybe to a lesser degree, but certainly the length to restenosis relationship might be changed. But that was exactly my concern. And I know we have two of the world's experts on the pharmacotherapeutics of PAD. And so I think exactly to your point, the male endpoint is a much more challenging one to get our heads around. And it's probably the non-interventional components that have a bearing. And your data actually point that out quite well. So, for those that would say this is an old data set, I think it resonates because it is fairly consistent with contemporary data. And so, Marc, how would you relate those male endpoints to what you saw in Voyager? And do you think the determinants would be similar even in a more contemporary cohort?
Yeah, that's a great question. I mean, there's always a lot of debate. Even we've seen this in some of the recent CLI trials of what is the right endpoint, what is the definition of male. For Voyager, the definition and what the FDA accepted was acute limb ischemia and major amputation of the vascular etiology. But there were a lot of minor amputations and other things that weren't included in there. And I think that the reason for those choices is that minor amputation is probably more of a microvascular issue, and it may be that other drugs like semaglutide or others that have an effect there. We've seen some of that for liraglutide. There was even a signal in prominent. So, when I look at the data, I think the definitions used are great, and I love the clarity of sort of breaking it out by the individual components. I think in terms of drug development, this is where we have to learn of what can you modify. And we're even, like, for example, the observation for LDL cholesterol, I think that really validates some of what we've seen in the PCSK9 literature. There's going to be data coming out for our bempedoic acid at the AHA and other places that validate the LDL hypothesis, and then lipoprotein little a. But, most of what we've seen for lipoprotein little a is what was seen in the study as those minor revascularization, progressive disease, and not male the way that it was described here. And so I think we have to be careful about how we extrapolate the potential benefits of those therapies.
Kevin, what about you? What do you think about the distinction between these two components?
Major and minor amputation. I think minor amputation is a tricky endpoint because sometimes that's a win in a CLTI patient. They undergo minor revascularization and you preserve a functional limb, and that could be a win. And sometimes that's how the patient comes to clinical attention. They have a minor amputation, maybe it doesn't heal, and then they come to clinical attention. So as far as a component of male, I kind of like major amputation. I think it's great to acknowledge both, because if we can figure out ways to avoid minor amputation with some of the medical therapies that Marc alluded to, that would be great too. So I love the clarity in defining both. I think moving forward, it would be good if all studies could use a standardized definition of male.
And so in terms of medical therapy, Scott, what was considered the standard of care during the era that these patients were treated? The VA is actually generally quite good about getting best-in-class meds to their patients. What do you think was characteristic of this group? And we'll compare and contrast to what a contemporary cohort might look like.
Well, the majority of these patients were on statins. I mean, we're talking about 80 or 90% in both centers, and aspirin, obviously, ACE inhibitors, and good blood pressure control. But, what we didn't have and what we didn't see was the PCSK9 inhibitors and some of the other lipid-lowering agents, which, potentially should have an impact, hopefully, on the major adverse limb events that we saw in this study as well. So I think that's a sort of promise based on the fact that people with residual elevated LDL cholesterol, even those on statin therapy, are at higher risk. So the obvious conclusion is get that lower, and perhaps they won't have a major adverse limb event.
And Mark, it's looking at those event curves, if you'd added low-dose rivaroxaban, what kind of a delta would you expect? Would it be Voyager-like, or would it be somewhat attenuated? And obviously the definitions being different, but what would you predict?
Yeah, I actually don't think that I wouldn't think of any reason why the relative benefit of rivaroxaban would be any different in this population. And we saw, 15% reduction in the primary endpoint, but that was really driven by male, at least as defined in the trial, which was a larger impact. In fact, in that population, it was a pretty sick population. We didn't see a mortality benefit or things that we're seeing. Compass was all driven by male. I think those relative benefits would be here. And then the absolute benefit would be dependent on just the risk of the cohort. You do wonder, as per Scott's comment, I mean, if you had everyone on a PCSK9 inhibitor with an LDL of 30 on rivaroxaban, maybe the GLP-1s, there's some signal in the FLOW trial, the combination of those therapies probably would have a pretty profound effect. And I think it's a good reminder that there's risk to modify.
So Scott, what are your plans to sort of extend some of the data? Are you going to follow these patients further out, or are you guys doing something prospective? What's the plan?
No, I think that's something that we're looking at. The question is whether we can do a multi-center trial using the VA database, for example. And I think a lot of people talked about that. The issue with that in the VA is that it's not collected to the same fine degree as we were able to do in this study. But that may just mean more hard work to try and find that information from the record. So these things are conceivable, but it's an interesting idea that I think we'd like to approach.
Well, certainly the VA is a treasure trove of opportunity for clinical learning and clinical management of patients, and obviously research in a pragmatic way. I'm sure Mark has a few ideas that he could throw your way. Take-home messages, Scott. What do you say to our readership and our audience? What are the take-home messages, and what are things that should give them pause as they're caring for these patients?
Well, I think that the big things are that patients who have long lesions, patients who have chronic limb-threatening ischemia, and some of these other factors that we identified, they identify your patients at high risk. They need closer follow-up. They need better surveillance. These aren't patients that you can sort of do a procedure and then let go into the community, because basically many people, many primary care physicians, many cardiologists aren't aware of the extreme risks that these patients face, as well as the importance of intensive risk factor modification. So that's really the key message. There are very simple characteristics that can identify your high-risk patient.
Fantastic. Well, listen, with that, I want to thank all of you guys, my friends and colleagues from a bygone era, for being here. And I want to thank all of our listeners and audience members for tuning in. The paper will be published online in JSCAI imminently, and we look forward to your responses and letters to the editor about the paper and its implications. I want to thank you again for listening to Conversations in Interventional Cardiology, and we look forward to seeing you next time. Thanks very much.